Welcome, everyone. Thank you for joining us. Our webinar today is entitled Utilizing the Rhythm Plus Profile, and our speaker is Dr. Stephen Goldman. My name is Lenore Powell. I am a medical education specialist in Genova's Atlanta branch, and I'm going to serve as your moderator for today's webinar. We would like to welcome Dr. Stephen Goldman. Dr. Goldman earned his Bachelor of Science degree from the University of Massachusetts. He received a doctorate of chiropractic from Cleveland Chiropractic College, where he also served as a member of the faculty. Following 25 years of family practice in Los Angeles, where he worked largely with athletes and patients concerned with optimal health, Dr. Goldman relocated to Asheville and joined the medical education team at Genova Diagnostics. As a medical education specialist, Dr. Goldman provides educational support to physicians and also authors medical education support materials. One of the most common questions that's asked during our webinar is about the availability of the presentation and the slide deck. These materials will be available on our website within a week of the webinar. If you are interested in having these resources, please click the Clinicians tab on the homepage, where you will find access to our webinars under medical education. Or you can also log into your MyGDX account to find these. And if you don't have a MyGDX account, please click on the Getting Started link on our homepage and follow the instructions to set up an account. I'm going to turn over the role of presenter to Dr. Goldman.
Welcome, everybody, for our webinar on utilizing the Rhythm Plus profile. I would point out that it's freezing here. I'm in Asheville, North Carolina. We had our first snow this morning, so all of you in warm weather, congratulations. And also hello to all of you out there who I know Lenore and I both speak to on the phone as medical education specialists at Genova, where we go through these tests and discuss them. And the Rhythm Plus profile is going to be our subject for today. So as we look at this, we have certain specific objectives. Our first objective is to assess the menstrual cycle utilizing salivary hormones. And we're going to review the components of the Rhythm Plus profile. In addition, we're going to discuss the HPA axis, which provides insight in terms of cortisol and melatonin circadian rhythms. So you're going to hear me say HPA axis an awful lot in the next hour. And we're going to discuss the cortisol awakening response, or CAR, which has various options, which is relatively new as far as a profile added to Genova Diagnostics. And we're going to utilize case studies to demonstrate the clinical utility of the test. So those are our objectives for today. And so let's begin with a look at the menstrual cycle. You can see on the right, we have a graphic of that. And so remember, the typical, and I use that in quotes, typical, it's certainly going to vary, but the typical cycle is a 28-day cycle comprised of two 14-day phases. So we have the follicular phase, which is the first 14 days and includes a buildup of estradiol followed by a spike likely caused by ovulation. And I say likely because we can't know with certainty from a test like this that the patient's ovulating, but it's certainly very suggestive when we see that spike. And then the second half, the second 14 days, is known as the luteal phase. And so that includes a luteal progesterone spike 7 days following the follicular spike. And we'll look at this again in more graphics as well. So a 28-day cycle, first 14 days follicular phase, second 14 the luteal phase. Both should have spikes that we're looking for as a pattern. And then changes in the length of a cycle are most often the result of a change in the length of the follicular phase. So if your patient has a 20-day cycle, likely that follicular phase is shortened. If they have a 35-day cycle, likely the follicular phase is lengthened. So again, same diagram. And what we see on the bottom here, this endometrial cycle, also called the uterine cycle, you can actually see the changes in the uterine lining here as we begin the cycle. And now we're in that follicular phase, and we have that buildup through the luteal phase. And this is all in preparation in case of ovulation, fertilization, that the uterine lining is prepared for that. And so you can see there's day 14, which should be in that 28-day cycle, the date of ovulation. Again, there's always going to be some degree of variation. Well, not always, but often there is. So let's take a look at how that cycle that I just showed you, those phases and ovulation, are represented on the rhythm test. So there you see estrogen, which is part of that, specifically that first half, although it's certainly part of both halves through the full cycle. But for that follicular phase, you'll see a rise in estrogen. You see it right here in this line. That's our estrogen and that increase. And that is represented here in the salivary estradiol progesterone of the rhythm test. So here we see the pattern for estrogen or estradiol for the follicular phase as it's represented. So the green overall is 2 standard deviations. The dark green indicates 1 standard deviation. So when you look at these, you can actually get a sense of where those spikes should be coming from. Now, progesterone is represented in the blue here. Again, we have the 2 standard deviation width of blue, and then the dark blue representing 1 standard deviation. I mentioned, again, there was a follicular spike, and there's a luteal phase spike, and you can see them, again, represented here. And there's ovulation on day 14. So it's our expectation that just before ovulation, as you see here with estrogen, that we should see some spike of estradiol. And so this arrow indicates between days 10 and 13, typically we should see that follicular phase spike that indicates a preparation right before ovulation occurs. And when we look at progesterone, we see again a spike there, typically about 7 days apart. So as represented on this test, you can see here, usually between days 19 to 21, one should see a luteal phase response. Again, with that luteal phase response, you know that you're having that uterine cycle where the endometrial lining is actually being prepared for a pregnancy. So this is the overall view of what we would see on the test. So again, there's our day 20. Now, I start here because when I look at this profile, I usually kind of start with the progesterone. I look for that luteal phase spike, and then I count backwards. So I look here and I see at the bottom of the page, you can see the actual numbers all lined up. I'm looking around day 20, and there's our elevation. There's our spike at day 20. And then I'm going to count back about 7 days looking for a spike of the estradiol, the follicular phase spike. So what I'm seeing here, it appears to be a pattern that speaks to a cycle. Now, there are other things I'm looking for. I'm looking at the testosterone, which is given here and reasonably hardy at 110. I'm also looking at what's the level of the estradiol? How is it relative to the progesterone? Am I seeing a dominance, a high estradiol relative to a low progesterone, or the other way around? Am I seeing it tail off at the end, which often in PMS is something that you'll see where estradiol and progesterone might just kind of drop off at the end of the cycle. So those are the insights I get just looking at this panel. This portion is the rhythm portion of the Rhythm Plus. So just to reiterate our key points here, the typical cycle is a 28-day cycle, and it's comprised of follicular and luteal phases. Changes in the length of the cycle are typically due to a change in the follicular phase, that first half. The cycle should include a follicular and luteal phase spike. The presence of a follicular spike suggests ovulation. It doesn't definitively confirm it. Now, having looked at that and looked at the cycle as a whole, it's always important to put it in perspective. When we're looking at hormones, we're looking at a balancing act. You know, we start with the adrenals, and we'll be talking about that a lot in the HPA axis and the level of cortisol. But the adrenals have a relationship with the thyroid, which we'll look at as well. And these also have a relationship with the balance of the sex hormones. And I say all this, but what I really want you to focus on when we get to a chart, a steroidogenic pathway chart, you really see clearly how these connections are made, how one thing always affects the other. It's a balancing act. So when we look at this HPA axis that I keep talking about, there are certain stresses that can occur. And there's, of course, a great number of stresses: oxidative stress, toxic exposure, infection, inflammation, the list goes on. But those stressors impact the HPA axis, the hypothalamic pituitary adrenal axis. And when that happens, there can be dysfunction of that axis, changes in the level of cortisol. And when that occurs, we're more at risk in terms of disease. And it's quite a lot. HPA dysfunction is associated with hypertension, cardiovascular disease, gut and immune dysregulation, a metabolic syndrome, diabetes, depression, fatigue, persistent pain. Again, a long list. So I think a main theme here is tracking that cycle, but also bearing in mind the impact of the HPA axis as part of that bigger picture. And so as a tie-in to the HPA axis, I'm going to also talk a little bit about the HPT, the thyroid axis as well, because these are all interconnected. And when we're treating our patient, we always want to know that we're getting to base causes, and these relationships are really how we do that. So with the HPA axis, it's the key to a balanced steroidogenic pathway. But when we introduce stress, it's going to stimulate the hypothalamus. So activation of the hypothalamus in response to stress produces glucocorticoids, but also has an impact because those glucocorticoids can inhibit the thyroid. So here we have our stress. We have the HPA axis side by side with the HPT axis to demonstrate this. So the hypothalamus is stimulated. Now, as far as the HPA axis is concerned, we have corticotropin releasing hormone. We have that hormone, which creates an inhibition to the production of TSH. We also have an increase in the adrenocorticotropic hormone, which leads to greater production from the adrenal cortex of cortisol. Cortisol also inhibits TSH, and that's going to influence levels of thyroxine. In addition, an increase in cortisol will lead to inhibition of the conversion of T4 into T3. So that inhibition of T4 to T3 and this interplay between the HPA axis and the thyroid, the HPT axis, means that higher release of cortisol due to various stressors is going to inhibit thyroid levels. So if we think about this clinically with some of our patients, if we have a patient with hypothyroid, clinical hypothyroidism as an example, and we decide to give them a thyroid support without addressing the HPA axis, we're really not getting to the likely cause here. We're not going to get a real change. We're going to be always caught in providing that thyroid support. So here's an example of the steroidogenic pathway. So if you look on the left here, you see how cholesterol brings us to pregnenolone, progesterone, aldosterone, and that leads us to the catabolic cortisol portion and to the anabolic growth and rebuilding, DHEA, testosterone. So I mentioned stressors, all those various stressors I talked about before: toxic exposure, physical stress, mental stress, infection, inflammation. And what happens with that stress is it creates that imbalance of the HPA axis. And with that imbalance, we find ourselves really taking the pregnenolone and progesterone, the precursors, in the direction of the production of cortisol. But remember, both cortisol and DHEA are made in the adrenal cortex, not only there, but a lot, and with the same precursors. So as the stress is bringing us to the cortisol, it may have an effect of lowering our production of DHEA, androstenedione. And remember, those aromatize androstenedione and eventually testosterone to make estrone and estradiol. So really, if you're not balancing this central anabolic catabolic portion of the steroidogenic pathway, it's very difficult to balance progesterone and estrogens. I really love this steroidogenic pathway at a glance chart. And if you go to our website and look at sample reports for complete hormones, this is part of that sample report. You'll see this pathway. I just like this one best. And so when we think about this HPA axis imbalance that I've been describing, stress alters the HPA axis balance, increasing the production of cortisol, which may impact thyroid. We just saw that. Increased cortisol, inhibiting thyroid production, but also create things like insulin resistance and rising insulin levels as well. So as the pregnenolone and progesterone are moving towards cortisol, lots of other stuff is going to get impacted. Stress alters the HPA axis, leading to an increase in mineralocorticoids. So you see those mineralocorticoids there. We don't often think about those when we look at this chart, but remember, that would stimulate the renin-angiotensin-aldosterone system, and that leads to tachycardia and elevated blood pressure. So again, the HPA axis reaching out and creating these changes, these imbalances. And as we noted earlier, less DHEA perhaps available, less estrogen made as a result as well. So it echoes throughout the steroidogenic pathway. I think this chart really gives us that full picture. So what are our key points here? The HPA axis influences hormonal balance. The HPA axis has an inhibitory effect on the HPT axis, which impacts thyroid hormone production. Cortisol influences pancreatic, liver, and gut function. Elevated cortisol influences insulin levels. So I have this slide here, which is conditions related to imbalanced hormones. And you can see this: weight gain, anxiety, fatigue, muscle mass loss, hair loss, all the way through brain fog, hot flashes. And what I find interesting about this, whenever I see these, I always think, I can think of at least 2 or 3 causes for each of these. So it's kind of confusing sometimes if you don't have a context to know where to begin. What should I be working on to really get a balance as far as hormones are concerned? Because all of these conditions can be related to hormonal changes. Hair loss, for example, hyperthyroidism, or maybe high androgens. So that's why having the HPA axis as a means in to trying to make that balance can really help with the overall balance and really address so many of these conditions that overlap. And so that brings us to the testing at Genova, the Rhythm and the Rhythm Plus. Now, the Rhythm test is what we looked at earlier, where we're really tracking the 28-day cycle with 11 different salivary samples plus another for testosterone. So that was where we looked at the estradiol, looked for that peak, the progesterone, looked for the luteal phase peak with 1 testosterone. This is a really a great way of tracking a full cycle. And it's such a great advantage, and we'll talk about that in a moment, of using saliva to track a full cycle as opposed to looking at one moment in time. Now, the Rhythm Plus has the same 11 salivary samples and the estradiol, progesterone, and the sample for testosterone, but it also includes an adrenal cortex stress profile, which can include a cortisol awakening response, or CAR. Now, CAR, as I said, is a new a tool that we have added to the adrenal cortex stress profile as an option, and we'll look at that as well. In addition, with the Rhythm Plus, we get a melatonin profile too, and we'll look at that as well. But why add an evaluation of the adrenals with this testing, with the CAR and with the 4-point cortisol and the DHEA? Well, because it gets us to an insight around the HPA axis. And I think that's a great add-on when you're looking at a cycle to also look at how the adrenals are functioning as well. So this was the Rhythm test I spoke about earlier. And what you're seeing here is that cycle, 11 samples, the various findings that we described earlier as far as testosterone, luteal phase, follicular phase. This is a look at the comprehensive melatonin profile that's part of the Rhythm Plus, where we're trying to get a better look at adrenal function and the HPA axis. And also we have the adrenal cortex stress profile with CAR. So this was CAR, the cortisol awakening response, that speaks to resiliency. And we'll talk about that just in a moment. But it gives us another point of view in terms of the production in the HPA axis of cortisol and resiliency, the ability to make cortisol, where the patient stands there. Now, what I call the hockey stick diagram is the 4-point cortisol. And this is the one where we're probably most accustomed to looking at, with the morning, 2 afternoons, and a late night 10 p.m. Cortisol finding, all saliva. And in addition, a DHEA finding. Here we're getting a look at the adrenals through cortisol and DHEA balance or lack of balance. So Why the Rhythm Plus? Well, as I said, salivary hormones provide the best insight into parent hormone levels. I was just asked a question before I started this webinar today about, well, what do you like about salivary hormones? Why would you use those over blood or urine? Well, salivary hormones provide great insight into parent hormones. By parent hormones, I mean estradiol, estrone, progesterone, testosterone. They give us the unbound bioavailable levels, and that's really important for us. Also, remember, cortisol, well, in the case of cortisol, but salivary hormones also allow us to look at something over a cycle. We're not just looking at one moment in time. And as you look at the various tests, for example, a rhythm test, you'll see how progesterone can go up and down and estrogen can go up and down. So it's so dependent if you're doing blood or urine, like where and what moment are you catching that measurement. But with the salivary hormones in the rhythm, we can really look at a full cycle. Urinary hormones measure metabolites. Now, metabolites are really great because they provide insight into detoxification pathways. So anytime you see a patient with a lot of estrogen or someone you're thinking about hormone therapy as an option, you want to see how are they detoxifying. So when we look at urine, we look at what's excreted, the metabolites. That provides us the insight which pathways are upregulated, which metabolites are higher or lower. Some of those metabolites, like in the case of estrogen, the 4-hydroxylated estrogen metabolite is a greater risk factor for breast cancer. Now, that's a whole other webinar, but I think it's important to note. So that's a great utilization of urine as far as the metabolites and detox pathways. Now, the rhythm profile provides the insight into premenopausal patients because it looks at the full cycle, not just selected moments in time. And I would say if you have a premenopausal patient and you want to get a sense of their balance or imbalance as far as hormones, this would be the profile that I would this would be my go-to profile. Now, patients should be encouraged, and when I speak to this on the phone, I always bring this up. I always say journal while you're doing this test. So you're doing 4 weeks of collection, the 11 different samples, because so often a patient will come to you and say, I have headaches and I think they're tied to my cycle. Well, if you're doing this test, keep a journal. Hey, on day 14, I started getting a headache. Well, once we have the test in front of us, we can look at what the progesterone and estradiol look like on that day. And we can get a sense of what imbalance may be causative. So it's a great test to use. I would always journal. For the patient, should always journal during the test. And I think the inclusion of the plus portion, the adrenal cortex stress profile, the comprehensive melatonin profile, really gives us insight regarding the HPA axis. And remember, when we looked at that steroidogenic pathway, that HPA axis really has a rippling effect across that steroidogenic pathway. Inflammation, toxic exposure, infection, all these things can influence the HPA axis. And that axis influences the steroidogenic pathway. Remember, that includes the production of estrogens and androgens. So this is what the rhythm test looks like. The Rhythm Plus includes a salivary cortisol 4-point, which is a diurnal circadian rhythm. Now notice the 11 a.m. to 3 p.m. Those findings, we tend to see a lot of fluctuation often because they can represent the stresses of that particular day. The 7 a.m. and the 10 p.m. are really insightful because when you start to see like a high 10 p.m. to 12 a.m. cortisol, you're likely dealing with a patient that's really having a hard time sleeping. Same with that high 7 a.m. They wake up like a shot. But the 11 a.m. to 3 p.m., it could mean, hey, I just came from the gym, or my kid is late for school and I have to rush them to, to the bus. Lots of fluctuation there. But we are very accustomed to looking at this diurnal circadian rhythm. Cortisol responds to stress, and that can disrupt the HPA axis. Elevated cortisol increases insulin resistance and glycemic dysregulation. So your insulin-resistant patients are going to also need to look at cortisol in the HPA axis. And elevated cortisol influences the circadian rhythm of hormones. Cortisol secretion increases in response to inflammation. The HPA axis influences the production of DHEA, testosterone, and estrogen. So I think by now you're hearing a theme here of how the HPA axis really influences all these other hormones and has to be evaluated along with the hormones downstream. So this is the adrenal cortex stress profile with the cortisol awakening response, or CAR. That's the CAR portion. It's really comprised of two findings. When you wake up, as soon as light hits your eyes, you do the salivary test. 30 minutes later, we would expect a surge, and we do a second test. So these two are utilized in the calculation for the percent increase, which should be 50% or greater. That would indicate resiliency in your ability to make cortisol. This third finding here is really the same as that 7 a.m. to 9 a.m. finding in the 4-point cortisol. So we're looking at resiliency, and then we're looking through the day at how the cortisol level looks, whether it's high, low, whether it has the rhythm one would expect. And we're also looking at the DHEA at 7 a.m. So we're comparing in this ratio the DHEA and the cortisol at 7 a.m. So the cortisol awakening response, or CAR, it's a transient increase upon awakening. As I said, what happens is you open your eyes, light gets into the eye, the retina, and it responds to this suprachiasmatic nucleus of the hypothalamus, which creates adrenal cortex secretion of cortisol. Now, the reason that's of interest to us is that we're accustomed to looking at this pathway, the hippocampus to the hypothalamus, to the anterior pituitary, to the adrenal cortex. This is that hockey stick that we look at throughout the day. But this is a separate, different pathway. So it provides a different insight as far as, are you able to make cortisol? Do you have a resilient capacity to do that? So it's a distinct physiologic mechanism, a pathway of its own. It's unrelated to the diurnal rhythm, that cortisol hockey stick rhythm. It's HPA axis resiliency and our ability to cope with anticipated stressors. And I think it's really interesting because they've done a study where they measured CAR on weekend mornings, and then they measured CAR during the week. Now, during the week, you know you have to get up and you have all the stresses of your job. They found the CAR was higher than on the weekends when you think, I can sleep in, I don't have the stresses of work. So it's really an anticipation of being able to drive that cortisol as you need it and the resiliency to do that, a different point of view. So in terms of our cortisol testing options, we have the basic adrenal cortex stress profile, the 4-point cortisol findings with the morning DHEA, the 7 a.m. and also all the way through 10 p.m. We also have this cortisol awakening response with the calculation of retinal light 30 minutes later, and then you can just choose to do the salivary cortisol the morning 7 a.m. to see how the cortisol looks when they wake and how it is at night before they go to bed in terms of how that might impact sleep. Now, if you want the full 4-point cortisol with CAR, that's also available, and that would give you the most information as far as the 4-point cortisol combined with CAR. The Rhythm Plus also has a comprehensive melatonin profile. And you can see here, there's a 7 a.m. to 9 a.m. reading, a 3 p.m. to 5 p.m., and then 2:30 a.m. to 3:30 a.m. Melatonin impacts the release of sex hormones. It can decrease the level of cortisol. Very typically, when you have high cortisol, you can have low melatonin. But sometimes what you'll see is an adaptive change, where when you have high cortisol, the melatonin will actually go up in an effort to bring down cortisol. So you may have that adaptive change as well. I found this a little surprising as I dug into melatonin. It's a strong antioxidant. We know that it influences mood and sleep, and it also works as an anti-inflammatory. So now we have a sense of the rhythm test, a look at the cycle, as well as the addition of the HPA axis through cortisol, the 4-point, and CAR. Let's put this in the context of some case studies. So I have a few studies here to look at with you. Case study number 1, we have a 22-year-old female. As far as her cycles, menarche was at age 13. She reports her cycles to be regular. weight gain around the waist, which, by the way, always makes me think about cortisol. Cortisol will certainly create that. Breast tenderness, sleep disturbances. Her thyroid is within normal limits. Her iron is within normal limits. Her fasting glucose is 109, hemoglobin A1C 5.8, fasting insulin 12. So that also makes me wonder about insulin resistance and blood sugar handling issues. Her lifestyle, it's somewhat stressful. She's a nursing student. She has a standard American diet, and she tends to be sedentary, not a lot of exercise. So this is the rhythm portion of the test. Again, I'm looking for the cycle. So the elevated estradiol with follicular spike you see on day 17. So my expectation would be about a week later, I should see a luteal phase progesterone spike as well. The luteal peak for the progesterone is on day 20. So to my thinking, I'm looking at a cycle. Now, what else can I see here? Well, the testosterone is within normal range, no issue there. But there's some overall imbalance, which suggests estrogen dominance. Look how high the estradiol is throughout the cycle. So when I look at this, I see kind of a drop-off at the end of the estradiol and progesterone, but more a concern here about estrogen dominance, that I'm always going to look at these findings and look at them as far as what the patient brings to the table in terms of symptoms. So again, estrogen dominance within the context of a cycle with a very reasonable testosterone finding. So what about her adrenal cortex stress profile? Her waking cortisol level appears to be normal. You can see that at that 7 a.m. to 9 a.m. Again, the green being a standard deviation. The two afternoon cortisol findings are elevated. Now, as I said earlier, that 11 a.m., 3 p.m. findings can often be very much reflective of what's going on that day for that patient. So it may reflect stresses specific to that day, but is also indicative of a strong stress response. Now look at that evening cortisol. That's elevated, and that would be consistent with sleep issues and the need to address adrenal balance. If a patient isn't sleeping well, it's really hard to balance them as far as hormones or anything else. So when we see that high 10 p.m. to 12 a.m. cortisol, we're really going to look at that carefully. Now, the DHEA is in the lower portion of the reference range at 126, but again, we're looking at one moment in time here, one morning DHEA, but still a little bit on the low end. So we're seeing a lot of cortisol during the day and before bedtime as well, and likely a lack of sleep as a result. High cortisol is associated, as I said earlier, with abdominal weight gain too. What about the melatonin? Well, her waking melatonin is well within the normal range. And by the way, that's really where you want to be. Although 5 or less is in the green, you want to be below that 5 if possible as far as the reference range. But the night level is kind of a high normal. Now, this can be an adaptive response to the elevated evening cortisol levels. Remember, we talked about that earlier. There tends to be an inverse relationship, high cortisol, low melatonin, but there can also be an adaptive change by melatonin to that high cortisol, and you'll start to see the melatonin rise as a result. So when we look at this morning, 7 a.m. to 9 a.m. cortisol, it looks really normal, right in the heart of the reference range, as does the melatonin. But when we look at that 10 p.m., as I said earlier, that higher cortisol, we also see what appears to be a bit of an elevation now in the melatonin. So that may represent that adaptive change where the melatonin rises in an effort to bring cortisol down. So what are our treatment options here? Well, she had elevated estrogen, so we would support estrogen detoxification, cruciferous vegetables, DIM, calcium D-glucarate to try to help lower circulating estrogens. And when I say detoxification, remember, when you see those high levels, you want to make sure they're able to detoxify. Those are the ways. But another test to think about would be a urine test, where you could actually see through a complete hormones how she's detoxifying through the metabolites of a urinary test. What are the pathways that are upregulated? Is she detoxifying in a less risk-inducing manner? Now, the adrenal support, there are a number of ways of going about this. Relora is an adrenal support. It's a supplement, and I mention it because it's an adaptogen that's got a good deal of research behind it. It's from Magnolia officinalis and Philodendron amurina. Oh, I can't say that. Amurans, excuse me, Relora. But it's a way of really utilizing an adaptogen to help with adrenal support. Remember, when you use glandulars, for example, there's a tendency to just increase cortisol, and sometimes that's not what you want to do. As far as nutrition, multivitamin, eat fatty fish, salmon, for example, 3 times a week. A Mediterranean diet tends to be a really good diet as far as overall levels of nutrients. You would want to increase cruciferous vegetables, antioxidant-rich foods, low mercury fish, and make sure she's well hydrated. And you want to certainly decrease processed foods. This young woman should not be on a standard American diet. The Mediterranean diet would be a good place to begin. As far as general, when you talk about high stress that may be leading to higher cortisol and insulin resistance, it's really easy to say to the patient, yeah, do something about your stress. It's so general and difficult. Most people need a protocol. HeartMath is a good place to look. It gives them a way of measuring stress and gives them an opportunity to really work on lowering those stress loads. Just saying, deal with your stress is not always going to get it done. And magnesium and phosphatidylserine can help to improve sleep as well. So that takes us to our case study number 2. Here we have a 36-year-old female. As far as her cycle, she cycles every 28 days. It'll be interesting to see how that plays out on the rhythm portion. She has dysmenorrhea, and she also has a 7-year-old child. As far as her labs, her standard labs and thyroid were within normal limit. Her BMI was within normal limits. We have someone who's really going to be exercising a lot here. She does have GI gut issues, constipation, abdominal discomfort. Her diet is a paleo diet, so that's likely a high protein, lower carb diet. As far as lifestyle, she describes herself as a weekend warrior. She's biking, she's running, she's rowing. She's getting 5 to 7 hours of sleep per night, which may or may not be enough for her. And she has a stressful occupation. So high stress, high exercise, GI issues, all to bear in mind here. So as far as her salivary estradiol and progesterone rhythm finding, her luteal phase, it's a peak at day 20. You see that at 6:49. And if I count back 7 days or so, there's a follicular spike at day 12. So day 20, luteal phase. So that means that the uterine lining has gotten the progesterone it needed. And the follicular phase, that spike, probably just before ovulation, if she's ovulating. It certainly looks that way. She mentioned a cycle that was pretty regular. That's what this looks like. That would be consistent. Now, also consider estrogen dominance during the follicular phase of the cycle. Look at her estradiol, and now look at her progesterone. Again, another reason why one would want to journal throughout this test. The testosterone is within normal range. So what about her adrenal cortex stress profile? Well, she has a high waking cortisol. She has a high evening cortisol. So she mentioned 5 to 7 hours sleep, but I'm guessing that she may have some difficulty getting that 5 to 7 hours fully. She has low DHEA with a high level of physical exercise, so a lower androgen, someone who's really exercising a lot. Just wanted to get a look at that. Now, what about her melatonin level? Well, although the 7 a.m. melatonin is in the reference range, it is in the higher end of the range. So, as I said earlier, 5 is really that endpoint, but you'd like to be a little bit lower. So there's some degree of a rise there. It's paired with an elevated morning cortisol. So that might be interpreted as an appropriate level of morning melatonin. She's a bit high in her cortisol in the morning, and she's just starting to get a little high, but still within the reference range of melatonin. A high evening cortisol can lead to an adaptive change in the nighttime melatonin over time, but it doesn't have to be over a long time. It's not necessarily chronic. So in other words, she had a really high level of cortisol at night, and we're starting to see actually kind of a lower melatonin. So are we seeing that adaptive change? It's essential that the patient does not collect melatonin in the presence of light. I bring that up because sometimes you'll be a little confused because you might see a really low melatonin at that 2:30 to 3:30, and maybe that's not what you expected. If there's too much light, that melatonin will drop as you're taking the sample. So let's see these side by side. There's that 7 a.m. Kind of high cortisol paired with the 7 a.m. Finding of melatonin, which is just kind of a little bit on the higher end of normal, but still normal. But there's that high 10 p.m. And kind of a lower melatonin. Again, perhaps a problem with collection, or perhaps we just haven't gotten to that adaptive change where you would expect the melatonin might start to go up to try to make an effort to bring down that evening cortisol. But that 10 p.m. elevation always makes you wonder about sleep. So what do we do for this patient? Well, again, adrenal support. There's a lot of cortisol that we saw there. So Relora or Rhodiola, another adaptogen, multivitamin, you want to make sure she's getting sleep. So magnesium, L-theanine to reset the HPA axis at night is very useful. Phosphatidylserine, often given 3 hours before bedtime. And then in general, again, the heart math, change from that high protein, maybe again to that Mediterranean style diet. An extreme diet does not work for everyone. And remember, she had those gut issues as well, which as a result, I would recommend a GI-Effects comprehensive test to see what kind of imbalances may be creating some of those GI symptoms. And with constipation and gut issues, are we seeing postprandial bloating, for example? A SIBO test would be a good way to get to the bottom of that, and probiotics to balance the gut and support detoxification. The GI-Effects can really help you get more specific in terms of how to address imbalances in the gut. And then, of course, the emphasis on helping her get more sleep, making sure she's getting rest. She's exercising hard. She's got a 7-year-old daughter. So that would be the approach for this patient. Our third and final case study, we have a 34-year-old female. She cycles every 28 days, although she has a difficult time maintaining pregnancy. Her labs and physical exam, low thyroid. She's not on meds. BMI within normal limit. Chronic constipation, so gut issues once again. Lifestyle, stressful job, anxious and irritable, and insufficient sleep. So I'm going to put this up and give you a minute to look at it. I've been doing all the talking. See what you think there. Okay, got it? So let's see what this looks like. A low progesterone throughout her cycle. Remember we talked about the need for progesterone for that uterine, the need for the uterine cycle, the progesterone to build up that uterine lining. She's having a difficult time with pregnancy. This is pretty much what you will see with that complaint over and over again on these tests. Very common. So she's low throughout her cycle. There's no luteal phase elevation detected. Her follicular spike is at day 11, so she has the spike. But without a luteal increase at around day 18, the uterine lining is not prepared for implantation. Her estradiol is robust. In fact, I would consider estrogen dominance as a possible issue here. Well, I mean, clearly with such low progesterone across the board, but this is certainly a pretty robust estradiol across the board. So her cortisol, elevated cortisol corresponds with her sleep issues, and maybe her gut issues and her thyroid issues. Look how high throughout the day and at 10 p.m. that is. And also, look how low her DHEA is. So low DHEA paired with elevated cortisol and hypothyroid reflect HPA imbalance, as we've been talking about. This would be a very dramatic demonstration of that. So consider DHEA support due to her low measured level. Her elevated cortisol is associated with reduced T3, T4 production. Remember, we looked at the thyroid versus the HPA axis. Continue monitoring her thyroid while supporting adrenal balance. Consider 1 year of nutraceutical treatment to correct that HPA axis. If it's disimbalanced, that really needs to be addressed before providing progesterone to promote pregnancy. Her morning melatonin appears well within the normal limits, so no adaptive change here. High cortisol, very normal looking melatonin, that's interesting. Her evening levels are on the lower end of normal and may be a response to the elevated evening cortisol, or again, an exposure to light while collecting the sample. But we're seeing kind of, that picture of low melatonin paired with relatively elevated cortisol. So elevation of evening melatonin may be an adaptive effort to suppress high evening cortisol, but we're not really seeing it. So here we see again, look how high that 10 p.m. is. Not particularly high there though. So the underlying theme here around looking at the cycle and looking at the balance of hormones is to address the HPA axis imbalance. That red arrow represents stress and imbalance. So with HPA imbalance, the patient can be expected to convert progesterone into higher levels of cortisol. Providing thyroid medication is less likely to be effective. High cortisol production leads to less availability of T3 and T4. One can provide DHEA while working to balance adrenal function since her levels are so low. So as we're looking at the adrenal cortex data, we can certainly provide DHEA while we're making that balance happen. But consider treating the HPA axis for as much as a year before supplementing progesterone to address a potential pregnancy. Remember, she has that really flat progesterone. One can provide progesterone to address symptoms of estrogen dominance, but progesterone to support a pregnancy should come after HPA axis balance is achieved. Okay, so in other words, we talked about that estrogen dominance. We want to really be able to detoxify all that estrogen, and we might even want to, while we're treating, boost that progesterone, support that progesterone. But as far as a pregnancy, once everything is balanced, that's the time to work with progesterone to that end. Once balanced, stop nutraceuticals before prescribing progesterone to support a pregnancy. So her HPA axis support, DHEA supplementation while balancing adrenal cortisol levels, the Relora to help, L-theanine, magnesium, things like Epsom salt baths for relaxation. Remember, she's anxious, needs time down, needs sleep, phosphatidylserine 3 hours before bed. Fix her HPA axis while monitoring her thyroid. Don't ignore that HPA axis and just go after that low thyroid. Generally, the Mediterranean diet, as we described earlier, as well as GI support, maybe a SIBO test as well as the GI effects, probiotics, multivitamin, and then the complete hormones, because we want to see how she's detoxifying all that estrogen. And that's going to be key as well as far as risk factors. So my summary of key points, we have a 28-day cycle generally comprised of a follicular and luteal phase, changes in the length of the cycle due to changes in the follicular phase. The cycle should include a follicular and luteal phase spike. The presence of a follicular spike suggests ovulation, but does not definitively confirm it. The HPA axis influences hormonal balance, and the HPA axis has an inhibitory effect on the HPT axis, which impacts thyroid hormone production. Cortisol influences pancreatic, liver, and gut function. And elevated cortisol influences insulin levels. And so with that, I am ready for some questions if we have them.
Absolutely. Thank you again for such a wonderful presentation. We did receive
Thank you.
Quite a few clinical questions. So let's go ahead and start with this one. There are many ways to assess hormones. You have saliva, blood, and urine. So when would you choose saliva testing over other specimen types?
Yeah, it's a great question. It comes up a lot, and it's so important in a clinical setting to know, to make the right choice. Specifically, salivary hormones provide you unbound levels. So when you're looking at blood, for example, you're looking generally, there are exceptions, at bound and unbound levels. So you might see a difference, for example, in the progesterone in blood the circulating level of progesterone, versus what you see in saliva. But in saliva, you know you're looking at pure unbound levels, bioavailable levels. With blood, you're looking at circulating levels that may be bound and unbound combined. In addition, with blood, you're generally, again, getting one moment in time. And I really think it's so important to reinforce that. When we look at this rhythm test and we look at the progesterone and we look at the estrogen, just think of how the moment in time that you chose to do that blood draw for the estradiol or the progesterone, is that going to reflect the whole, that month? So the saliva really gives you that leeway with cortisol, with progesterone, with estradiol, to see a cycle, to see a much fuller picture. And that's why I say if you have a premenopausal patient, that's the test I would run. The urine, the urinary testing, like the complete hormones, the essential estrogens, look at the metabolites. The metabolites can sometimes reflect more upregulated pathways where these metabolites are more risk-inducing. So for those of you who do urinary testing, you know that the phase 1 estrone estradiol metabolite, the 2-hydroxylated form, is considered risk-reducing. But the 4-hydroxylated form can really be potentially very risk-inducing. So again, I think the saliva gives you those pure unbound levels for the parent hormones. Blood is a good way to look, but you're looking at what's circulating in the blood. People are very comfortable because they've been using blood for so long, and it's fine. But you're also generally getting bound and unbound levels of these parent hormones. And again, the urine, really more about looking at the metabolites in terms of assessing risk and helping design a protocol to minimize that risk.
Thank you. We received another great question. What would a perimenopausal rhythm test look like?
That is an interesting question. And it's interesting in that I would suggest this test really is geared towards someone who is premenopausal. But sometimes we may have patients that we're not quite certain yet. And so we may actually be looking at a perimenopausal picture inadvertently. And typically what you're going to hear about is, you know, my cycle is 28 days. I could, you know, always depend on that number. Lately, it's 20 days or it's 30 days. Sometimes I skip a cycle. You're generally dealing with a perimenopausal patient, and you're likely to see more fluctuation in the levels of estradiol and progesterone. You're not going to see that clear spike followed a week later by a second spike. You're likely to see changes in the length of the follicular spike if it's there because the length of the cycle changes so much. So it's really that fluctuation. And by the way, that also makes a really great case for the Rhythm Plus, although in that case, if I knew my patient was perimenopausal, I would just do an adrenal cortex stress profile with CAR because remember, the big change between premenopause, perimenopause, and menopause is that premenopausally, you're making these sex hormones predominantly from ovarian production. Perimenopause is really a shift from that production in the ovaries to more adrenal production. Not only adrenal production, but the adrenals certainly take a much larger role. And so how well you do with that symptomatically with that perimenopause is really going to be so much about that HPA axis, the balance of the adrenals, to allow the adrenals to take on that task of being more responsible for the production of sex hormones. But I would, again, getting back to the original question, I would think of this as really a test for a premenopausal female and not perimenopausal, although it does come up because sometimes they're still cycling, but their cycles are kind of harder and harder to time and anticipate.
Another question, if you have an estrogen spike followed by a progesterone peak, can you assume that ovulation has occurred?
It's likely, but you can't know. A scan of the ovary would probably be the way to know. But if a patient does have that follicular spike, and then it comes down, and then they have that luteal phase spike, it's very likely. But you can't, and I think I point that out in the slides, you can't know with certainty, but it's very likely.
And for our final question, Can you please review how stress and cortisol can impact thyroid hormone output?
Well, I think we really delved into that a great deal, but it's always a great question to think about when you're treating your patient, because we have a tendency to look at one individually. It's like we're playing whack-a-mole, like, oh, low thyroid, give them thyroid because they have low thyroid, and we're seeing that clinically. But as we saw on the slide that had the HPA axis side by side with the HPT axis, there's really direct interaction that's occurring there. We really are on a balancing act as far as these are concerned. And so as we saw with greater production of cortisol, with imbalance of that HPA axis due to stressors, we're going to see that higher cortisol, the higher CRH, ACTH are going to first lower TSH and also block the conversion of T4 to T3. And remember, T3 is the most active of the thyroid hormones. So we always have that going on, and that's why when we look at that pyramid, it really starts at the base with the adrenals and then moves to the thyroid and then to the sex hormones. And if you just look at the tip of the iceberg, the sex hormones, in isolation, you're missing a big part of that pyramid. If you just look at the thyroid, same thing. And so if there's an underlying theme here, it's really looking at the fuller picture. And to do that, one must always take the HPA axis into account.
In the interest of time, we will end our question and answer period there. So for additional education materials, we'd like to encourage you to visit our website, www.gdx.net. On this site, you'll find sample reports, kit instructions, and more information for each of our profiles. After taking advantage of the materials found on our website, please contact Client Services with additional questions. You'll see a contact number on the slide for both U.S. and U.K. customer service. Additionally, please call Client Services if you need assistance in setting up a MyGDX account. We also offer complimentary appointments with our medical education specialists to answer questions related to our testing, including choosing the right test and reviewing patient test results. We'd like to encourage you to register for our upcoming webinars on www.gdx.net. So in the month of January, we will have Dr. Jill Carnahan presenting a few cases on GI and SIBO, or small intestinal bacteria overgrowth. In February, we will have Dr. Filomena Trindade presenting on menopause, insulin resistance, and Alzheimer's, discussing the link. In March, we'll have Dr. Pam Smith discussing male hormones. And finally, in April, we'll have Dr. Goldman back again to present more information on female hormones and review a few more cases. I'd like to thank you again, Dr. Goldman. That was an excellent, super presentation, and I hope that the attendees learned as much as I did from listening to you today.